Hi, and welcome to the June 26, 2013 Plastic and Reconstructive Surgery Journal Club, held at St Vincent's Hospital in Sydney. My name is Damien Marici. I'm a plastic and reconstructive surgeon. This is Dr. Miriam Sayed-Adabi, who is the unaccredited registrar at the Children's Hospital at Westmead. So, Miriam, today we did the usual 4 papers. The first paper we looked at was the management of fibrous dysplasia in the Zygomaticomaxillary region, outcomes of surgical intervention, and this was from Gabbay et al. In Los Angeles, California. So what was this paper about?
Yeah, look, this paper was a retrospective study of a number of patients from a single unit that underwent therapy for fibrous dysplasia. And as you said, they looked at the outcome of what was the reoccurrence rate, a number of times going back to surgery, and the satisfaction of the patients and the surgeons. The patients were 97 patients all up, with various forms of fibrous dysplasia, monostotic and polyostotic.
And they even had a few who had the whole shebang with the McCune-Albright syndrome. It really was a very large number of patients, being 97. And I guess one of the key things that the group was looking at was comparing minimal surgery or burring or debulking compared with radical excision of the area of fibrous dysplasia with reconstruction. And their main reconstructive area technique was with split calvarial bone grafting.
That's right. And so they looked at 58 patients in total in the Zygomaticomaxillary complex, and they found that the patients that had the radical resection had obviously a much lower reoccurrence rate and reduced number of reoperations compared to the patients that had the contouring for symmetry procedure.
But the flip side of that was there was a higher complication rate in the radical resection group. And some of the complications were quite significant complications. One of the things we were discussing about this paper, even though the conclusions of the paper were quite gung-ho in favour of radical resection, and radical resection obviously is the only treatment which offers the potential for cure from fibrous dysplasia. But even though the number of procedures was larger in the burring group, one would imagine that you'll be having a number of small procedures if you want to go burring of the fibrous dysplasia, as opposed to at least one very large, potentially morbid procedure with the radical excision and reconstruction group.
That's right, and especially seeing that the both patient satisfaction and surgeon satisfaction were not significantly different in the two groups, one would wonder that, knowing that the complication rates were so much higher in the radical resection group, the real gain of one versus the other, I guess, is still up for grabs.
Yeah. So that was a very interesting paper. Now, the second paper we looked at was another craniofacial paper. This was a craniometric analysis of posterior cranial vault distraction osteogenesis, and this was from the Children's Hospital of Philadelphia, published in PRS this year. So this paper was basically looking at children who had brachycephaly and underwent a posterior vault expansion, but using distraction. There was a wide age range from children, I think from around 3 months of age.
That's right, to about 14 years old.
Yes.
And there was 22 patients in total, and they had a protocol of inserting the distractors and having a cooling off period, and then distracting really until their endpoint being a slight overcorrection. And then keeping the distractors in for at least 2 months or so, taking them out, and then performing a post-op CT and looking at their measurements. And in specifically, they looked at the cranial vault volumes, and then they looked at the cranial vault height at various points of the head. So looking posteriorly, middle, and anterior, as well as looking at any possible changes in the morphology.
And their results were great. They showed obviously not only an increase in overall intracranial volume, but interestingly, there was an improvement in the nasofrontal angle, which is important for those children who suffer from frontal bossing. So one of the suggestions they made was that by performing a posterior vault expansion using distraction osteogenesis, it can improve the frontal bossing and then delay the need for any urgent frontal orbital advancement procedure, and possibly even delay things until the patient requires a monoblock procedure. So I thought it was very interesting. In the unit which I'm a part of, we do posterior vault expansion using spring, doing a spring. That tends to be in children who are under 6 months of age. We do use distraction osteogenesis for older children, and I thought that this was a very interesting technique.
Yeah, look, I think that was the general consensus of the group as well, that it was quite a good paper and a very nice technique that was described.
Okay, the last two papers concern facial allotransplantation, which is obviously a huge topic of increasing popularity. No face transplants have been performed in Australia to date, and I think probably less than 25 have been performed in the world. So one of the papers, the first paper we looked at, we're looking at nerve transfers for facial transplantation, a cadaveric study for motor and sensory restoration by Audolfsson et al. In Dallas, Texas, and this was published in PRS. So what were they basically looking at in this paper?
So look, they looked at the feasibility, I guess initially the anatomy and the length of possible nerves for attaining both sensation and motor, so specifically looking at the length that you can get from branches of the cervical plexus, and as well as the supraorbital nerve and the mental nerve.
Yeah, so basically they were looking at the cervical plexus as a potential transfer to the mental nerve, the supraorbital nerve as a potential transfer to the infraorbital nerve, those representing 2 of the 3 trigeminal nerve branches providing sensation. And then for motor function for the facial nerve, looking at the nerve to masseter.
That's right. Yeah. So, and look, their findings was significant in that they certainly showed at least a theoretical possibility of such procedures being an option if the need was to arise. And I guess that's important for people that are embarking on such procedures as the facial transplants, as the stumps may not always be available in the recipient due to the nature of the initial trauma or insult that was already attained.
Yeah. And speaking of experience with facial transplantation, the Boston group, headed by Julian Prebaz, published also in this year's PRS, Current Principles of Facial Allotransplantation, the Brigham and Women's Hospital Experience. So what was the...
Yeah, look, this was a interesting paper, and the reflections on their experience, and really what they stressed on a number of points which are significant. The first being really surgical safety, and really stressing on the points that the transplants to date in their experience have been that the workup has been very important, and planning the surgery, and really stressing that it's an elective procedure that requires a great deal of workup, as the consequences of not working up can be disastrous. They also talk about the technical feasibility and the time restraints that need to be looked at when you're embarking on such a procedure, and so therefore within that you need to consider the minimum or number of vascular anastomosis that are required, as they give a 4-hour window from taking of the transplant to vascularizing it.
Yeah, one of the big points they also made was that you need to preserve fallback options in case the face transplant doesn't work for whatever reason. And so they said even though that may increase the technical complexity of the surgery itself, you need to have a fallback position if it all goes to pot.
Yeah, and I think it was interesting that they talk about the fact that really if these transplants at one stage are rejected, or through the procedure you realize that it's not going to happen, it's important that you try the best that you can so that the patient is not in a worse off position than they were. And I guess that's going on to the point of really leaving any functional units that are already present, instead of trying to, I guess, have a quicker procedure or a technically easier procedure by doing a complete block as well, instead of segmenting it.
Yeah. Okay, well that was it. It was a fantastic journal club as usual. Mariam did an amazing job as our presenter today. So for those of you who were there, thanks for being there. And for those of you watching now, thank you for listening. Okay, bye.